These days, the majority of my caseload relates to continuing health care for families who have a member of the family going into care, and the question which arises then is how that's going to be funded and how that's going to be paid for. There are three regimes of funding for care in this country. The sort of work that we specialise in is the third type of funding regime, which is what's called continuing NHS care funding. Anybody who goes into care, perhaps being discharged from hospital, and goes into care, who has a primary health need, and that's the key phrase here, is going to remain the responsibility of the state. Not means tested, but paid for entirely by the state, by the NHS. If you have a member of your family who is about to or is going to care or who is in care, the question really that we seek to address is whether or not they should be paying for it or whether it should be paid for by the state. Those whose primary need is to be given help with washing and dressing, getting up in the morning, that sort of thing, they will be social care needs and not primary health needs. Those perhaps who may be diagnosed with cancer or some other awful thing, who require a great deal of nursing input and care input from the health perspective, are more likely to be qualifying individuals for the purpose of what we call CHC funding, continuing healthcare funding. Now, the government are proposing last year about bringing in a cap on care fees of £75,000. That legislation, if it ever comes in, will not actually take effect until about 2017. So we're still left at the moment with an uncapped, open-ended liability for fees. And so anyone in the position that I described earlier, where they've got a house, where they've got other assets, is going to be looking down the wrong end of a loss of £25,000, £30,000 per annum for however long they survive.